We can start. Okay.
Okay, so I'd like to welcome everyone to the afternoon session of our webinar. For the next session, we will be discussing about the comparison between EUS-BD, PTBD, and Enteroscopy-guided ERCP. And it is my pleasure to introduce our first speaker of this afternoon, Marc Giovaninni. He's from Marseille, France. He's one of the pioneers in this area of EUS-BD. And it's really my pleasure to introduce Marc, please.
Okay, thank you, Natalie, and thank you for the invitation to give me the opportunity today to speak about EUS-BD. This is the question: EUS-BD versus PTBD. Is the EUS-BD always preferred? And we will see the. Here you can see on this slide the three technique of EUS-BD, and the first is the EUS choledochoduodenostomy with the direct puncture of the CBD and the insertion of a metallic stent or a 10 millimeter axial stent. The second technique is the hepaticogastrostomy, which is the drainage of the left lobe into the stomach, with the drainage of the complete liver if the stenosis is located in a lower part of the CBD. And the third technique, which is less used, is the anterograde stenting. Is the same technique than the hepaticogastrostomy, but the stent is pushed into the duodenum anterogradely through the stenosis. But to answer to the question, there is the answer will be different. We have a different clinical situation. The first and the main indication is the malignant stenosis of the CBD, of the lower part of the CBD, mainly pancreatic cancer, and the use of the EUS or the PTBD is in patient with normal anatomy in case of failure of ERCP, in case of duodenal obstruction or for altered anatomy. The second situation is a benign condition, and also we have two different clinical situations: patient with normal anatomy and failure of RCP, and also altered anatomy. And the third, which is very interesting, because we have now some paper that the use of the EUS in patient with malignant hilar structure. We will see these three situations. The first is the malignant stenosis of the CBD. And today in the literature, we have a lot of paper. This is one of the more recent about the safety of the choledochoduodenostomy with the recent paper. It was a systematic review. You see in this review, we have around 600 patients. You see that what is important is the pool rate of all adverse events is now inferior to 15%. Mainly the complication is not the bile leakage, which is now less than 4%, but also cholangitis. But this cholangitis is not an EV complication. The most EV complication is the bile leakage, and you see now with the new stent, there is a reduction, a dramatic reduction of the bile leakage. And on this group, if you use lamps, you see that also the rate of complication is lower than if you use a standard stent, in particular for the choledochoduodenostomy.
Marc, I'm sorry. Can you put your slide on the slideshow mode?
Sorry.
Thank you. Thank you so much. Sorry for the interruption.
No, this is better. Okay. And this is just a clinical case of a patient with a duodenal obstruction with a previous stent in place. And you see that this is not an easy situation because the ducts are not dilated. Here you see there is some air with pus inside the bile duct, but this patient was a failure in other hospital of the PTBD. It was stent for drainage, and you see the main advantage that of the EUS, even if the duct is not dilated, is possible to target this small stent with a needle. And here you see the opacification, and you see this patient with a previous stent, a duodenal obstruction, and the goal after is after to obtain the cholangiogram is to insert a guide wire and to use the cystostom to create this is the cystostom 6 French to create the anastomosis between the left lobe and the stomach, and after to insert a Giobor stent. This is a special stent dedicated for the hepatico-gastrostomy to obtain the anastomosis here between the stomach and the left lobe. This is one of the main indication. Here you can see on the literature the comparison, the study on EUS-guided biliary drainage versus percutaneous, and if you see that the adverse event rate was always, even if the previous study, lower in the arm using the EUS guidance, and also the reintervention rate was lower if you use the EUS route. And it's for this reason that today this is the results of a more recent meta-analysis. This meta-analysis for the patient with a malignant obstruction of the lower part of the CBD show that the EUS-BD is associated with a better clinical success, less post-procedure adverse event, and a lower rate of reintervention, and also the stay in the hospital of the patient is reduced if you use the EUS route. And for this indication today, the EUS route is preferred to the PTBD in patient in which the ERCP fail, or patient with duodenal obstruction or altered anatomy. Benign stenosis of CBD stone is different. It's different because we face to a patient with a benign disease, and there is a very few paper in the literature. There is only these two papers, one from Japan. This is from our unit, and you see mainly the use of the EUS is in patient with altered anatomy. Why? Because it's very rare that the ERCP fail to cannulate a patient with a CBD stone or malignant benign stenosis. It's mainly the main indication is the anastomotic biliary stricture after surgery, after Whipple surgery for a benign lesion as IPMN or a benign cystic lesion. And you see, this is the paper from Japan. They include 26 patients, but technical success was only 50% in this study. But when the technical success was ready, was good, the clinical success was also very good with 100% of clinical success with no complication, no huge complication in this paper. This is our paper published this year. You see that the indication are anastomotic biliary stricture in patient with 12 patients with a Whipple resection, and you see that the clinical success was very high. It's 12 under 13 patients, but you see the complication rate was in 4 patients with 3 cholangitis and 1 bleeding, but not biliary leakage. But this is normal because mainly when the patient are operated, the risk of leakage is reduced. one case that I want to show you, and sorry, this is during my my live course. It was a patient with a CBD stone and an intradiverticular papilla. It was not possible to cannulate the papilla with. And we decided to do a rendezvous technique, which is mainly the technique that we use in case. And again, here you see that the CBD is not dilated, and this patient has had an acute pancreatitis 3 or 4 months before, a mild pancreatitis, and you see here the opacification of this normal CBD. And you see the stone, and after we pass the wire, and the wire will go into the duodenum. And you see also the position of the scope. It's a long position, but it's different than the position that we use for the choledochoduodenostomy, in which the scope is more high. Here you see the passage of the wire into the duodenum, and after we exchange the scope for a duodenoscope, and we finish the RCP. In patient with stenosis, this is a patient with anastomotic stricture after Whipple resection, and this patient developed recurrent cholangitis. You see the technique is 2-step. The first step is the puncture of the left lobe, the left biliary duct, segment 2 or segment 3. I prefer the segment 3, and is the insertion of a fully covered stent with a double pigtail, a long double pigtail, and we try to pass the anastomosis to do a dilation with 8 or 10 millimeter balloon, and this is the CT with the stent and the pigtail inside. And 1 month after, we come back, we remove the fully covered stent, and we replace the stent by 1 or 2 or 3 plastic double pigtail plastic stent to calibrate the anastomosis. And we do this during 1 year, 1 year and a half, or 2 years. It depends of the stenosis. And we can insert 2 or 3 or 4 plastic stents to achieve the calibration of the stenosis. There is no comparative data between EUS-BD versus PTBD for benign condition, but we prefer now to use the EUS-BD route because it's easier, because for the PTBD, mainly we face with patient with normal bile duct or very mild dilation of the bile ducts, and also the complication rate is higher for PTBD because mainly we face the patient operated with a previous surgery in which the fibrosis induced by the surgery reduce dramatically the risk of bile leakage. Now, the last part of my talk is the malignant hilar stricture. And the question is how to drain the right lobe with the EUS. And you will see that today is possible to access to the right lobe. And this is one of the best indication of the EUS in patients with Klatskin tumor. This is a type 2, and the right lobe was drained using the endoscopic route, and the left was drained using the EUS route, and we have this kind of nice image on the plane X-ray with the 2 stents and the complete drainage of the liver. Also, in this patient with a type 4, 3 stents were inserted using the endoscopic route, and the left lobe was drained using the EUS route. And this is the final drainage of this huge and complex Klatskin tumor with 4 stents, 1, 2, 3, and 4. with a complete drainage. And this is very important to achieve a complete drainage. You will see on the recent paper of that we were published in 2019 that the complete drainage is associated with a longer survival time of the patient, and also if you treat this patient by chemotherapy or radiochemotherapy, if you leave a part of the liver not drained, this can induce cholangitis or hepatic abscess during the treatment. Alors, how to drain the right lobe, and this is one of the huge question, burning question today. You have two techniques. The most difficult is the hepaticoduodenostomy. This could be possible if the anterior segment is dilated, and you can do the same technique than the hepaticogastrostomy for this segment. But the technique that I prefer is a so-called bridging technique. I will show you this video of the bridging technique. And this is a patient with a type 2, because this is the main indication is the type 2 bismuth hilar tumor. And the first step is the puncture of the segment 2 or segment 3 of the left lobe, like an hepaticogastrostomy, and you will see here the needle, the puncture of the dilated duct. We obtain the cholangiogram here, and you see. And after we introduced the wire here was into the CBDs. Is not the way that we want, but with the cystostome, and we can, and if you use an angulated wire with some manipulation, we finally success to pass into the right lobe through the stenosis. Here you will see the wire pass, and it's very important to have the cystostome, because with the cystostome, and if you use the current, we can create a channel through the tumor, and we insert deeply in the right lobe the cystostome. And also cystostome is very useful because we can inject, and we can obtain the cholangiogram of the right lobe like this. And after the trick is to insert an uncovered stent 6 centimeters to do the connection between the right lobe and the left lobe. Previously, we have performed a dilation of the stenosis with a 4 millimeter balloon. Here you see and this is the insertion of the uncovered stent. Here you see the opening of the uncovered stent to create the communication between the right lobe and the left lobe, and after we insert a Jobber stent to create the anastomosis between the left lobe and the stomach. I go a little bit quickly. Here you see the opening of the Jobber stent, 8 centimeters. And you will see the final results. And this is the final results. We leave in place a nasobiliary drain just to prevent and with this complete drainage using the EUS route. Sorry. This is the paper published in the literature. We have 3 studies. It's a total of 25 patients. It's not a huge series, but you see that mainly the indication are hilar stenosis, and here you see type 2, and we use metal stent. You see that this is our paper that the morbidity rate is quite high, 4 patients on 12. but these complications were managed medically. Only one patient needed to be re-endoscopy for bleeding, and you see one patient died in this study after the procedure. But you see that it was mainly type 2, but some also more advanced hilar cancer. And why is it important to use this and to try to have a maximum of liver segment drain in these patients? And it's for this reason that in this case the PTBD and the EUS are not enemy, but they are more friends. And this is the paper that we published last year. And you see, if you have more than 80% of the liver drain, this increase the survival rate of the patient, and also in the 71% of the patient we can restart the treatment, and this is a very important, in particular for the patient in which the hilar infiltration is due by metastasis for breast cancer or colon cancer, because we have effective chemotherapy today. And it's very important to obtain a very good drainage. You see that in this patient, we use the association of EUS and PTBD and ERCP in 5% of case. And you see that we combine all the technique that we have for the complete drainage of this disease. And you see it's a mainly metallic stent. And to conclude, EUS-BD is preferred to PTBD for the drainage of the bile duct in case of malignant stenosis of the CBD when the RCP fail, in case of malignant involvement of the duodenum or altered anatomy. EUS-BD is probably better to use than PTBD for benign stenosis, but mainly the technique is the rendezvous technique if the anatomy is normal, or the hepaticogastrostomy using the two-step with the fully covered stent, and after the plastic stent for patients with stricture of the biliodigestive anastomosis. And the EUS can drain the right lobe in some condition, but for malignant hilar stricture, EUS and PTBD can be associated. And I hope to, that you can join us in September for your 4th edition of EUS Endo, which due to the pandemic will be an EUS Endo, 7 and 18 September. Thank you very much for your attention.
Thank you, Marc. That was excellent. I think we have a couple of minutes to take questions. There are some questions from the audience, Marc. First question, in bridging technique, once both metallic stents are deployed, why is nasal biliary tube is inserted? Can we put contrast immediately and check for leak, and so that this can avoid NB2?
Sorry, I don't.
Oh, in the bridging technique that you mentioned, right, bridge technique. After you put in 2 metallic stents,
yes,
you said you inserted nasal biliary tube. Is
yes,
that right?
Yes.
The question is that why do we need to insert that? Can we just check from? Yeah.
No. Now we stop to insert the nasobiliary drain. This is why, because if we have a migration of the hepaticogastrostomy stent, we have always an access to the bile duct with the nasobiliary drain, and it's easy to reinsert a wire and to try to save the situation, to put another stent inside the hepaticogastrostomy in case of migration hepatogastroscopy. But today, the risk of migration is quite zero, and we prefer to leave the patient without biliary drain, or if the endoscopist is anxious, he will leave a double pictate stent in place.
Okay, great. One more question, Mark. Do you have any special techniques to puncture the right lobe of the liver duct?
The right lobe is it's always the segment 6, or that we succeed to. Now the technique is to first of all, you should put the patient on prone position on the back, and to put the scope in with 180 degrees rotation just after the bulbous at the level of the genus superius, and in this position, if the segment 6 is dilated, you can have an access to the segment 6, and after the technique is the same than the hepaticogastroscopy. But the main problem is the insertion of the needle, because when you insert the 19-gauge needle in this position, sometimes it's difficult. Sometimes you succeed, but you lose your EUS image. And if the duct is, you have a huge dilation of the duct, I prefer to use the Zimon pre-cutting accessory that is more floppy, but you have only. You should success your puncture of the duct. You have only one chance to puncture the duct with the Zimon, because you use the current cutting to go inside the duct. And also the other complication, the other difficulty is that the puncture is always perpendicular to the scope. And if you want to insert a wire, you need to use an angulated wire, and a 0025 inch wire, which is better to manipulate. It's not an easy procedure, and it's for this reason that I prefer to use the bridging technique when it's possible.
Okay, very good. Thank you, Mark.
Thank you.
I think Supo has just joined us.
Yes. It's my pleasure to introduce Marc Kida as our next speaker in this session. And his topic will be EUS-BD versus Enteroscopy-guided ERCP, which is preferred. Please, Marc Kida.
Yes. Hey, I am waiting for so long time. Yes, and today I'm talking about biliary intervention in patients with surgically altered anatomy, and the EUS-BD or enteroscopy. So the indication of the EUS-BD in accessory papilla, such as the duodenostenosis due to the malignancy and subsurgical altered anatomy, and also rescue procedure after failed ERCP, and so on. So there are several routes, as you know, the EUS-BD from the hepaticogastroscopy, choledochoduodenoscopy, and also there are anterograde and rendezvous technique. So there are a lot of reports. At the moment, more than 1,000 cases, the technical success is 91%, clinical success is 87%, complication is 29%. So EUS-BD or EUS-BD, ERBD or PTBD, which is better? So according to the recent meta-analysis done by the mirror, compared with the ERCP, there is no significant difference on the technical success for the PTCD, and also there's no significant difference on technical success. And however, the adverse event, concerning about adverse event, compared with the ERCP, there is no significant difference. But compared with the PTBD, PTBD has a much more adverse event. And this is for the disturbed malignant biliary obstruction. Concerning about technical success and clinical success, there is no significant difference between the EUS-BD and versus and ERCP. So this is concerning about adverse event and also the re-intervention. So concerning about the adverse event, there is no significant difference between the EUS-BD versus ERCP. However, concerning about re-intervention, the EUS-BD has more or less re-intervention rate. So this is summary. If you have the optimal expert for the EUS-BD available, then EUS-BD introduces a similar result for ERBD or PTBD. And on contrary, there is a lot of the experience and expert for PTBD in the most of the hospitals. So that is also true. So due to the lack of the dedicated tool, the procedure can be technically challenging in many patients. So EUS-CDS or EUS-HDS, which is better? This is also the international multi-center retrospective trial done by the Kashyap. The level is nearly of the same. The ranges and the hospital stay is a little bit longer in the HDS. Technical success is nearly of the same, 93, 91%. And procedure duration is 51 minutes and 45 minutes. And this is a patency of the stent. And CDS versus HGS. Concerning about the stent patency, there is no significant difference. And also concerning about the overall survival is also nearly the same. This is meta-analysis for the clinical success and the CDS and versus HGS. So there's done by the Webler. This is also the difference between CDS and HDS on clinical success. Concerning about the adverse event, CDS and HDS is also no significant difference. However, spectrum is different. CDS has much more cholangitis compared with HDS. And on the other hand, concerning about the migration, HDS has a much more migration rate compared with the CDS. But totally, there is no significant difference between adverse events in these two groups. So there's another way to approach to the surgically altered anatomy cases. So there is a short bowel endoscope. We use the short type SBE. The short type has around 50 centimeters shorter than the normal SBE. And also the short type has a much bigger channel, the 3.2 millimeter compared with the 2.8 millimeter in the long type. So because of the big channel, we can introduce the guide wire system, the guide wire basket, guide wire IDUS, guide wire EML, like this. So this is a CO2 inflation guidance. Look for the right route. at first, put in the endoscope and feel the CO2 and X-ray route, right route. We can save time because of the CO2 inflation guidance. So this is our result. And, reaching the blind end rate is little bit lower in the Roux-en-Y without gastrectomy case, the 68%. Compared to the other group has more than the 90%. We can reach the blind end. So the reason of this reason is mainly the not enough ranges with short type SBE. Then if you employ the long type SBE, the most of case can be reached to the blind end up to the 85%. So this is a complication rate of the short SBE ERCP. The pancreatitis is, I cannot see the slides, but anyway, the several percent. Power ratio of 1%, bleeding is also the 1%, meningitis around 1 point something. Not so high. According to the systematic review of the meta-analysis, Dr. Inamuda said that it should be considered the first line intervention for the surgical anatomy cases. The HGS and Enteroscopy ERCP, which is better? Of course, the EUS-BD is much easier to approach access to the interhepatic bile duct if the interhepatic bile duct is dilated. And using the endoscopy around 65%, around 65%, the technical success is much lower than the EUS-BD. That is also true. However, the concerning about the clinical success is a little bit higher with the EUS-BD. Concerning about the adverse event, the EUS-BD is much higher than compared with the ERCP. That is also true. So this is the case of the interhepatic bile duct stone that we employ the long SBE. Even though we employ the long SBE, we cannot reach to the blind end. Then we switch to the EUS-HGS. At first, we puncture the interhepatic bile duct and feel the contrast. And we put in the guide wire, pass through the guide wire beside the big stone. Over there, there is a healing effect. And at first, we dilate the balloon with hepatico or jejunostomy with the balloon. After that, we push that stone by the balloon like this. Then finally, we remove that all big stone like this, completely removed into the jejunum. So this is the multi-center retrospective study done by the USTA. But however, the US antegrade treatment of the bile duct stone is around 72%. The maximum size is only the 10 millimeters. So this is the Tiber, the Army Tiber, the study. They also tried antegrade hepatico or antegrade clearance of the bile duct stone. But for the big stone, they take sometimes almost 100 days. it is necessary to create the fistula. And then after that, they dilate the fistula. Then they employ the EHL, and sometimes the small baby scope, EHL under the baby scope, like this. It takes long time, like this. But however, if you employ the small enteroscopy, this is a very big stone. Then we reach the blind end. Then we dilate the EPLBD. Then we directly insert the bioduct enteroscopy. Then crush this big stone by the EHL under the endoscopic guidance, like this. So using the small bowel enteroscopy, it is sometimes we can treat the bioduct stone at the one session, even though the stone is very 5%. That is also a problem. But for the benign such as the stone and stenosis of the hepaticojejunostomy, in this situation, I believe the small bowel endoscopy is much better than the EUS. Finally, we tried this technique, the 14 cases. All the cases can be treated by the one session. And also, there is this is for the viewing echo endoscope. This is also sometimes very helpful. So there is a complete obstruction of the hepaticojejunostomy. Then we insert the forward viewing endoscope as an enteroscopy. We reach to the liver hilar. Then we puncture the interhepatic bile duct directly. I cut the, sorry, I cut the USB pictures. But anyway, we can puncture the interhepatic bile duct under the EUS guidance, like this. After that, dilate, and finally we insert the covered metallic stent, like this. Like this. We can treat this stricture by the EUS metallic stent, like this, like this. So if you have the expert EUS-BD introduce the similar efficacy and PTBD, sometimes more than the PTBD. If you have the expert EUS-BD introduce the similar efficacy of the EUS-BD. So there is no significant difference between the ECDS and the HGS. In surgical altered anatomy patients, HGS has a higher success rate but higher adverse event compared to the enteroscopy. Using the forward viewing echo endoscopy, it is feasible to perform the corticojejunostomy in patients with the surgical altered anatomy. For the malignant lesion, for the drainage, maybe the EUS-HGS, EUS-BD is much easier, but for the benign lesion, we have to think about the treatment techniques, the EUS-BD or enteroscopy ERCP, especially the bile duct stone and the stenosis of the anastomosis. Thank you for kind attention. This is our staff.
Okay, thank you, Professor Kida. Excellent talk. And I think there are no incoming. I have one question for you, Professor Kida. Professor Kida?
Yes.
Yeah, for the eye intrahepatic stone, hepatical branch of left IHD, which do you prefer? Multiple HGS with stone clearance or enteroscope ERCP?
I show our result at the moment in our department. Our first choice is enteroscopy because the approach to the light off, and also if succeed, we can treat the bijuxtone in one session. That is our message.